Welcome. Today we're diving into prominent ear correction, really focusing on the core principles for assessment and surgery.
Sounds good. Let's kick off with the basic anatomy of the external ear.
Okay. So laterally, the skin's thin, quite adherent.
Exactly, thin and stuck down. Medially, though, it's much looser, thicker, more fibrofatty tissue there.
Growth-wise, they get big pretty quickly, don't they?
They do. About 85% of adult size by age 3, with matures around, say, 6 for girls, 7 for boys. Length takes a bit longer, into early teens.
Right, and that early cartilage, it's quite different.
Oh, definitely. In neonates, it's remarkably pliable. That's down to, the lingering maternal hormones.
Makes sense. So it gets stiffer later on.
It does. Increases in stiffness, can even calcify with age. But that early malleability is key for non-surgical approaches.
Let's touch on the embryology briefly. Where does it all come from?
Okay, so two main players. The first, branchial arch, that gives rise to the tragus, the root of the helix, and the upper part of the helix.
And the second arch.
The second, or hyoid arch, forms basically the rest, antihelix, antitragus, the lobule. So the lower two-thirds, roughly.
And they start sticking out from the head around 3-4 months in utero.
Yeah, around that time gestationally.
Okay. What about blood supply? Critical for surgery.
Absolutely. It's all terminal branches from the external carotid, primarily the posterior auricular artery and the superficial temporal artery.
Got it. And nerves. Seems complex.
It is. You've got the auriculotemporal nerve, that's a branch of E3, the trigeminal, that does the tragus and crus hilicis.
Okay.
Then the main player is the great auricular nerve from the cervical plexus, C2 and C3 roots, that covers most of the rest, anteriorly and posteriorly.
And there's the vagus too, right? Arnold's nerve.
Yes, the auricular branch of the vagus nerve supplies sensation deeper in the external acoustic meatus, and sometimes the lesser occipital contributes a bit posteriorly.
Right. So moving towards correction, what are the normal aesthetic goals we're aiming for in otoplasty?
Well, first, you want to correct any protrusion, especially in that upper third. The helix should sort of sweep gracefully and be visible just beyond the antihelix from the front.
A smooth contour, no sharp edges.
Exactly. And you absolutely want to avoid messing up the postauricular sulcus, no major shallowing or distortion.
And there are specific measurements for projection.
Yes, the helix to mastoid distance. Typically about 10, 12 millimeters superiorly, 16, 18 mid-ear, and maybe 20, 22 inferiorly at the lobule level, roughly.
And symmetry is key.
Crucial. Aiming for within, say, 3 millimeters difference between the two sides, ideally.
Well, what else defines a normal-looking ear aesthetically?
A smooth, well-defined, rounded antihelical fold is really important. The angle between the concha and the scaphoid fossa, the conchoscaphal angle, should be around 90 degrees.
So fixing that angle is often part of it.
Often, yes. Or sometimes you need conchal reduction itself, or altering the conchomastoidal angle. And typically, the helical rim should project a bit more laterally than the lobule does.
Okay. How common are prominent ears?
They're relatively common, actually. Maybe around 5% in Caucasian populations.
Yeah.
Tends to run in families, autosomal dominant trait.
And while it's not a functional problem, it can cause issues.
Definitely psychological impact, particularly for children facing teasing at school. That's often the main driver for seeking correction.
And the common causes anatomically.
Usually it's one or both of two main things.
Mm-hmm.
The antihelical fold isn't developed properly, it's too flat, or the conchal wall, the cartilage bowl, is just too deep or overdeveloped.
So preoperative assessment, what are you looking for specifically?
You need to carefully assess that antihelical fold. How defined is it? Look at the depths of the conchal bowl. Check the lobule, its position. Any specific deformity there?
And the overall angle.
Yes, the angle between the helical rim and the mastoid plane. And you need to get a feel for the cartilage itself, its quality, its springiness. Is it soft or stiff?
Any other things to note?
Absolutely. Look for associated features. Does the patient have a Stahl's ear deformity, a prominent Darwin's tubercle? Is the mastoid bone itself prominent? All need consideration.
So to recap the main features of the prominent ear itself.
Usually it's that poorly defined antihelical fold. The conchoscaphal angle is often more obtuse, greater than 90 degrees. Sorry, I misspoke earlier. It's usually greater than 90 degrees in prominent ears, making it flatter. Less than 90 degrees is the goal.
Ah, right. Greater than 90 degrees makes it look flatter, less folded. Okay.
Exactly. And then there's often conchal excess, which you can usually assess by gently pressing the helical rim medially. If the concha seems to be the main thing pushing it out, that points to excess.
You mentioned non-surgical options earlier for neonates.
Yes, that window in the first few weeks, maybe up to 72 hours ideally to start, You exploit that hormone-influenced cartilage pliability
How does that work?
using molding techniques, things like custom or commercial splints, taping, even gluing. It needs continuous molding for about 6 to 8 weeks.
And it can work?
It can potentially avoid surgery altogether if started early and done diligently. Worth considering for newborns.
Okay, but for most patients, it's surgery. What are the surgical goals mirroring the aesthetics we discussed?
Pretty much. Complete correction of that upper third protrusion. Making sure the helix is visible beyond the antihelix from the front view, ideally the whole length.
Smooth helix? Deal with any Darwin's tubercle.
Right. Preserve the post-tracheal sulcus. Get those helix to mastoid distances right. 10, 12 millimeter top, 16, 18 millimeter middle, 20, 22 millimeter bottom.
And symmetry.
Symmetry within 3 millimeter.
What about timing for surgery?
Usually linked to auricular growth, and when kids start school, the ear is nearly adult size by 6 or 7.
So surgery around then.
Typically, yes, though you can consider it as early as age 5 if the child is mature enough to cooperate with the postoperative care.
And the surgery doesn't stop the ear growing afterwards.
No, studies suggest growth continues normally after otoplasty.
Okay, let's get into the techniques. What are the main approaches?
Broadly, you can think about cartilage molding or shaping with sutures, cartilage scoring, or cartilage breaking technique.
Most common ones.
Probably the Mustard technique, which is cartilage molding for the antihelix, and the furnace technique, also molding but focused on the concha. Then there are cartilage breaking approaches like Converse and Woodsmith.
Others like Stenstrom, Chungchit.
Yes, those are primarily cartilage scoring techniques. The principle there is that if you score or cut cartilage on one side, it tends to curl away from that cut surface.
How does that work for the antihelix?
You typically score the lateral-anterior surface, often through small subcutaneous pockets from a posterior incision, to avoid scars on the front of the ear. The scoring helps it bend backwards.
Okay, let's break down the main ones. Mustard.
Right. Mustard is great for recreating that antihelical fold, especially if it's poorly defined, or for upper third issues. You mark the desired fold, usually make a posterior approach, maybe excise some skin.
Then sutures.
Then you place permanent mattress sutures, usually horizontally, going through the cartilage from the scaphoid fossa to the concha, effectively cinching it to create the fold. Then tie them down carefully.
Anything to watch out for?
You have to be careful not to make the fold too sharp, and importantly, not to narrow the external auditory canal entrance when placing those sutures.
Okay. And furnace.
Furnace is more for tackling conchal excess, often contributing to prominence in the upper two-thirds. Again, posterior approach, skin excision.
What's the target for the sutures here?
You dissect down to expose the postauricular muscles and fascia over the mastoid. Careful of the great auricular nerve branches here. You might resect some mastoid fascia. Then permanent mattress sutures go from the posterior aspect of the conchal cartilage to the mastoid fascia or periosteum.
Pulling the concha back towards the head.
Exactly, retropositions the concha. You can sometimes use flaps of mastoid fascia to bolster the fixation.
And the cartilage breaking ones, like Converse Woodsmith, when are they used?
More often for stiffer cartilage, maybe in young adults or adults, or for more severe deformities involving significant conchal excess, loss of the antihelical fold, and that increased conchoscapal angle. The main risk is creating sharp edges or contour irregularities
Oh.
because you're actually cutting through the cartilage.
How's it done?
Marking, posterior skin resection. Then you make sharp incisions through the cartilage along the planned antihelix. Use mattress sutures to reshape the antihelix, sometimes excising excess conchal cartilage directly, and then suture the concha and antihelix together carefully.
What about the lobule, the lower third? Sometimes that sticks out too.
Yeah, that needs specific attention. A common technique is a modified fishtail excision, described by Woodsmith, basically extending the postauricular incision down in a V shape to resect skin and soft tissue and reposition the lobule.
In either way.
Another approach involves dissecting the posterior aspect of the antitragus and suturing it back to the inferior concha to pull the lobule in.
Are there adjunctive things for specific findings?
Sure. If there's a prominent Darwin's tubercle, you can usually just excise at full thickness.
Stall's ear.
That needs careful handling. Because the upper pole prominence can be prone to relapse, you often need specific techniques directed at that third crus.
And if the mastoid bone itself is prominent,
You might need soft tissue resection over it, or sometimes even burring down the cortical bone slightly for contour.
okay. Let's talk complications. What's the most immediate worry?
Hematoma, definitely the most common early issue. Suspect it if there's sudden, usually unilateral, severe pain after surgery.
Management.
Urgent. Dressing needs to come down, Maybe remove a suture or two, evacuate the clot. If there's active bleeding, back to theater for hemostasis. Then redressing needs prompt action.
Infection.
Less common, thankfully. Usually staph for strep, sometimes Pseudomonas. Good sterile technique is key. If infection occurs, especially if it involves the cartilage chondritis that's serious,
Chondritis management.
needs aggressive treatment,
Mhm.
often requires re-exploration, excision of any necrotic cartilage, and appropriate antibiotics, sometimes topical agents like sulfamylon are used to, can lead to significant long-term deformity if not managed properly.
What about late problems? Deformity recurrence.
Late deformity can happen, usually shows up within the first 6 months. It's often more operator-dependent or related to the technique used.
Any difference between techniques?
Some studies suggest higher reoperation rates with suture-only techniques like Mustard, often due to suture extrusion or breakage compared to scoring techniques like Stenstrom. Cartilage breaking techniques might have a higher risk of contour irregularities, those sharp edges.
You hear about telephone ear deformity.
Yes, that's where the middle part of the ear gets pulled in too tightly, but the top and bottom stick out, often due to not adequately addressing the entire cartilaginous framework or breaking the spring of the cartilage appropriately.
Okay, let's try to summarize the key takeaways from this deep dive.
Right. So remember that early neonatal cartilage pliability, it offers a window for non-surgical molding. Autoplasty surgery is typically done around school age 6 or 7.
The main anatomical issues are usually a poor antihelical fold, that increased consiscapal angle, or conchal excess, or a combination.
Exactly. And the surgical approaches fall into 3 main camps. Cartilage scoring, cartilage molding with sutures like Mustard or Furnas, or cartilage breaking techniques like Converse.
And vigilance for complications is vital.
Absolutely. Yeah. Early and aggressive management of hematoma and infection, especially chondritis, is crucial to prevent poor outcomes. And be aware that long-term deformity or recurrence is possible, influenced by technique and surgeon factors.
So a thorough grasp of this complex anatomy and the different surgical strategies is really essential for anyone performing otoplasty to get consistently good results. Definitely warrants ongoing study of the finer points of each technique.